All right, shall we?
Let's do
We
it.
shall.
We shall. All right, let's do this. So, I'm Chris, and with us too is Dr. Proctor, and happy Friday, first of all. So it's a pleasure to be here. So we've done this two other times this week. So you guys are the diehards to show up on Friday afternoon, which is pretty awesome. And hopefully we will give you a good show, good presentation, I should say. But so this is the first part of the ATC series that some of our folks have come up with and are launching. And the next one is actually going to be laser. So we'll be talking about. So this is a high power laser. So we'll be talking about laser for the next one. So look for that in September. And I guess we'll see what happens this afternoon and whether or not you want to come back and listen to us. But we'll keep our crossed. So we're going to talk about radio pressure waves. So sort of this intro about, what it is and what we can do with it. We'll do a little bit of demonstration. And at the end, so we do present our email addresses, even, through the registration. You'll be able to get some further information. Our wonderful, amazing manager of event planning, Judy Taylor, is actually on with us. And so she'll take care of certificates and things like that. So any questions, you can give her a holla. But without further ado, let me put us on with a Dr. Proctor.
Hello, everyone. Good afternoon on this side of the world. On the other side, good morning. So we are going to talk a little bit about radial pressure wave today. And we'll mention another device called the focus shock wave just in brief. But again, most of what we're going to do today is radial pressure wave. We always like to put our conflict of interest statement right up front. Yes, we are both employees of a company that manufactures and sells these devices. So we will, get that information out of the way, and we'll start the program.
Do we get commission?
Tell people when we start these programs, I always like to say that, we need to think a little bit differently. We need, this is not the modalities that you are used to utilizing. This is something totally different. This is something unique. And I know a lot of times, we get folks and, we get this idea that we can do everything that we need with our hands, that we may or may not need those physical agents. And it's Dr. Prue and I's mission to actually try to convince folks that we may have some answers for you to help you do what you do with your hands. So, I ask you to think a little bit differently. Some people say think outside the box. I'm the guy that says throw the box away, because the second half of that quote right there is that without imagination, there is no future.
If not, will at least make you raise more questions.
Very good. Exactly. So, we do want to say this. We're not trying to replace your hands. We're not trying to replace what you do with your hands. Your hands are amazing tools. They do a lot every day. We ask them to do a lot every day. The problem is, one day, if you're lucky, you're going to get my age. And when you get old like me and you've got CMC degeneration of both thumbs, some of the things that I do with my hands aren't fun anymore. Some of those things become painful. So I try to find things that will assist in what I do with my hands. So we're not replacing those hands, but what we want to do is show you something that can make what you do with your hands easier and possibly more effective so that you get better outcomes. And that's what this is all about, is creating those outcomes that help you with your patients and make you a better clinician. Yes, we are talking about another physical agent, another modality. And of course, the way we always teach therapeutic modalities is we talk about creating an environment. We talk about enhancing the environment in the injury state. And what we do is we create that environment with the idea that we are going to allow healing to occur in an optimal amount of time. And so we talk about, heat, light, sound, all of those things. And today, The radial pressure wave is an example of one of those physical agents, and the modality or the energy source itself is acoustic in nature. So we're going to be talking about sound wave energy. Again, it's acoustic energy like ultrasound, but it's a little different. There's some things that we'll go through that Dr. Prue and I will talk about in this part. So when we start talking about radial pressure wave, we do talk about things that happen in nature. Where did this energy come from? Where did all of this start? And very simply, if you look at the history of this device, we start talking about that, you know, it began with injuries that they saw in World War II, where sailors might have had to jump ship. There were bombs that were dropped in the water. The percussion that was created that went through the water actually fractured lungs of those folks in the water. We also need to say that, you know, this energy occurs in nature. So if you've ever been in the thunderstorm and the lightning, you see the flash, and then later on you hear the boom, and maybe you feel your house shake just a little bit. That's the sound wave occurring in nature, if you will. So let's see, I'm having a little issue here. So let's talk about extracorporeal shock wave and where it all began. 1966, there was a test being done. They were firing a projectile against a metal plate. There was a person standing near that metal plate, and when the projectile struck the plate, the person standing there said, "Wow, I felt a shock go up my arm." And so again, they tested the room, they looked, there was no electricity in that area, none of that in that component. And what they found was that it was the percussive energy that the person felt. So hence the name shock wave came. 1971, they did the first disintegration of a kidney stone with this extracorporeal shock wave, and they called it lithotripsy. And so again, they used that energy to burst the stone so that it would be in smaller pieces and could leave the urinary tract. So now, what we see here in this next picture, you'll see that that's the energy, and that was the idea behind breaking up the kidney stone. The interesting thing is that they got to looking at this and they said, now what if we lowered the amount of energy? What if at that point after we lowered the energy, could we do therapy with this device? And so from that, we wound up with extracorporeal shockwave therapy. So initially when they started this, and again, very simply, you know, they would use the energy, they would put it on the part and impart that energy into the tissues. What they determined is that, you know, there's a lot of energy there. And so they were using anesthetics. They were actually doing injections so that they could do this on a patient. That limited who could utilize the device. So from there again, now we talk about we dropped the power again. And when they dropped the power again, they figured out, now wait a minute, we're actually changing this environment in the tissue. We can now do it without any anesthesia or any injections in the area. And so because of that, we can now treat things that we've never treated before. And so with the energy low enough, we actually stimulate the cells and those physiological processes. And note, we talk about everything from cell and tissue regeneration to reducing pain. And yes, there is data out there where we talk about non-union fractures and even acute fractures, those kinds of things. So you're all familiar with things, and usually the term I throw out there first is the Graston Tool. Again, some of this early stuff was called gua sha. And if you look at it, what we do with Graston tools, Hawk grips, any of these types of appliances, we take a tool and we put it on the surface of the skin. We put downward pressure on the skin. Then we drag that across the surface of the skin. The idea is that we're going to stimulate the tissue, and actually we're going to create an insult. And in this case, with all that bruising, you're creating a secondary injury, basically. We're pushing things into an acute stage. So therefore, if we have this chronic situation, we push it into an acute stage, we reestablish the inflammatory process, and when we reestablish the inflammatory process, we basically get this inflammation and this healing back on track. So while all of that looks as if we have created this injury and we're getting this healing, there's another thing we have to think about. When you use this device, you actually put downward pressure on the tissue. So if we're trying to really get to deep tissue, you're going to crush and do some things superficially. So again, we go back to the idea that we're creating that secondary injury. So we go back, and a lot of this goes all the way back to Cyriax, and Cyriax was the guy who wrote all the books on the friction massage, kind of the first one to really push that. And he talked about a controlled clinical insult. He talked about breaking down scar tissue, okay? So that was the big thing for years when we talked about friction massage, when manual therapy techniques, some of the trigger point therapies where we put pressure on those areas first started, we started talking about we're breaking down scar tissue. Well, when in fact, we technically didn't break down scar tissue, what we did was re-stimulate that inflammatory process. And by doing that, apoptosis took over. And so now that tissue was reabsorbed, and then the natural healing process was allowed to occur. So then the tissue was remodeled to tissue like in the area where the scar tissue was. So we want to change the terminology here. We're not breaking down scar tissue. What we're actually doing is we are disrupting the tissue matrix, okay? We don't destroy anything. We don't break anything down. But what we do is create inflammation. And by creating inflammation, we wind up getting those tissues that are scar tissues, calcifications, not like the tissues in the area to be reabsorbed. So again, acoustic wave therapy, we're going to talk about radial pressure wave. We're going to talk about shock wave. Those are the two things that we have to talk about, or the two devices that we have to talk about today a little bit. So the idea is what we're going to do, we're going to re-stimulate that healing process in chronic tissues. My thing always is I look at some of the other things we use and we take a chronic situation and we push it back into an acute situation. What if we took that chronic situation, instead of pushing it into an acute system again, why don't we use a little less power, we focus it a little better, and now let's create a subacute situation so we don't create that secondary injury. So we're not asking healing to go start over from the get-go. So again, we said earlier, this is energy like ultrasound. Please understand, when we talk about ultrasound, the energy comes in very quick pulses. We talk about 1 million pulses per second. Here we're talking about reducing that frequency down somewhere between 1 and 21 pulses per second. So the power, the pressure of this device, very large peaks. They hit very hard. They last a period of time. So we're talking about delivering a significant amount of energy in an extremely short period of time. So the idea is we're going to take that energy, we're going to place it on the tissue. We pull the trigger on the device. Dr. Prue is going to demonstrate that in just a little bit. And so now as that wave enters the tissues, it's going to be dissipated throughout the tissue. So basically, it's going to be absorbed by the tissues. It'll be absorbed superficially at first, and then through the idea of resonance, it's actually going to penetrate the tissues a little deeper. And as the sound energy accumulates in the tissues, we will actually get a deeper accumulation or a greater depth of penetration, because we talk about this device penetrating somewhere around between 5 and 6 centimeters deep. So again, you're going to find out, again, with Dr. Prue, we've got different tips, different applicators. He's going to talk about those and how they change the depth of penetration. But the other thing that we have to remember is, sound energy travels through a medium. And since it travels through a medium, we've got to have something for it to travel through. So you'll see that we'll use gel with it like ultrasound. Now, if you wanted to lessen the power, guess what? You could do it without without the gel, and by doing that, you would reduce the amount of energy that's transmitted into the tissue. So again, this is a picture of the device. We put the device on the tissue. As the device begins to impart the energy, over time, the amount of energy that is absorbed by the tissue begins to go deeper. So this next slide, what you'll see is this thermal imaging, and you see these nice, pretty colors. You know, the first thing we see is that, okay, after a few shocks in the first photograph, we get a certain depth of penetration. But as the number of shocks accumulate, look at the volume of tissue and the depth of penetration that we talk about with this energy. So now what we can do is we can actually impart energy into the tissue, do very little, if any, damage to the superficial tissues, but now we can go much deeper, much more comfortably for this patient. I don't know if you've done those Graston tools and other things. I've seen people push on those things, you know, and every time you look at the patient's face, they are in a lot of pain. They don't really enjoy it because it's not comfortable. Whereas with this device, I can impart this energy. I can do so relatively comfortably for that patient and not do the damage superficially to the tissues. So we can get the same effect, but again, I'm not doing all of that work. Like I said, this is all about your hands. So now I'm going to put that device on there. I'm going to let the device do the work. Dr. Prue's going to do the demo, but he'll tell you, you know, you're going to find the spot, you're going to put it on the owie, and wherever the owie is, you're going to apply it there, and it's a lot less work on you. And then you supplement this with the things that you do with your hands. So again, there are two devices. There's one called the radial pressure wave. The other one's called the focused shock wave with radial pressure wave. What you see, if you look at the charts below, and in just a second, we'll show the overlay of those two things. But the radial pressure wave, again, is a pneumatic energy source. The focused shock wave is an electromagnetic source. And so pneumatic versus electromagnetic, the interesting thing is about the radial pressure wave is the greatest amount of energy is going to be at the tip. And you'll see there in this photograph that the energy leaves the tip of the applicator on the right-hand side, and it spreads or it disperses as it goes through the tissue. The focused shock wave unit, which we won't talk about today very much, but the energy actually is created in the periphery electromagnetically, and then it is very focused. It's a very specific point that it's going to hit. And the depth of penetration with that device is significantly different. It's somewhere around 13 centimeters. Here's the overlay of those two graphs that I wanted you to see, because the shockwave device, the energy is imparted very quickly at a much higher level, so we get better levels of penetration. Not only that, it's more comfortable for the patient. The radial pressure wave is applied over time, just a little more time. We're still talking about very, very short periods of time. So again, the patient will feel it. At any rate, what you're seeing with that, there is a positive pressure, there is a negative pressure. So when we look at this, you know, as soon as the energy is imparted, there's this positive compression pressure on the tissues. And then there is going to be this rebound where it actually goes below what normal is, and there's the negative pressure. That negative pressure is what we sometimes speak of as cavitation. And what we talk about is this negative pressure that creates this environment for us to get the healing to begin. So again, let's talk about the term tissue matrix disruption. When we talk about tissue matrix disruption, please understand, we're not creating another injury. That is one of my biggest concerns about some of the things we do now when we leave a patient. And now we've got that ecchymosis in the tissue. We've got some swelling in the tissue. Now the patient is a little more sore, a little more painful. The question is, did we really need to go that far? Did we really need to create that in order to get this healing to occur? In my opinion is no, because now what I can do with the device we're talking about is I can impart this energy, and instead of creating another injury, I can basically disrupt the tissue matrix. I can change this chronic cycle that we're stuck in of inflammation and force it back into that subacute cycle, where now we reboot the entire healing process and we start over and we give apoptosis a chance to clean that area out of any scar tissue or calcification that may be in the area. So again, there's just a couple of slides here. If you look at this one, you'll see we're going to talk about there is mechanical energy. It is that mechanical energy that is used to create a chemical response. So now we're going to take and we're going to convert this mechanical energy in the tissues to create this mechanical response, or this chemical response, where we actually release inflammatory mediators. We'll talk substance P, we'll talk nitric oxide, we'll talk cytochrome C oxidase. All of these things are going to be players in this. And again, all of this is done by first creating compression and a shearing force and a tension that again is going to stress the tissue. And by stressing the tissue matrix disruption, by doing this, we are actually going to create the healing environment that we're after. So I mentioned substance P and I mentioned nitric oxide. Again, we talk about inflammatory mediators. And so we talk about what these are going to do when they're released. And again, you'll see there's a blood vessel here. So let's talk about what happens. We're definitely going to increase microcirculation. So therefore, we're going to increase the metabolism of that cell. That occurs because of some of that negative pressure, okay? So the neat thing is, yeah, we're also going to now begin to modulate the inflammatory process. Again, push it from chronic to subacute. I do not want to overtreat the patient. This is important, and Dr. Pruitt will talk about it. We don't want to overtreat because we don't want to create those secondary effects, right? We don't want the side effects. What we want is to go into a subacute so that we can restage this inflammatory process. Yes, we're going to vasodilate vessels into the area. And the other thing that is very interesting here is we're going to talk about Neo-Angiogenesis. We're going to talk about, a lot of people talk about capillary budding and reintroduction of blood flow into an area because the blood flow has been disrupted by the injury, and blood flow is supposed to remain in a vessel, but now it gets outside and it becomes a very caustic thing in those tissues. So now there's no blood flow because it's all been sealed off. We've got to get blood flow back there before the healing can occur. What you're going to see here on these pictures, this is a radiograph of a guinea pig hind leg, and you'll look at photographs A and C. These are where injuries were introduced into that hind leg of a guinea pig. You'll see the femur and the tibia. But what I want you to notice is in the control group, where there was no intervention there, you'll see there's a disruption of circulation. And now look after 28 days, yes, there's blood flow reintroduced, the normal cycle of inflammation and healing, and we get that capillary regrowth into the area. The interesting thing is, look at the leg that was treated with a radial pressure wave. After 28 days, there is a significant amount of blood flow that's been introduced to that area. So we now talk about improving this neo-angiogenesis. So again, we're talking about inflammation. We're talking about the repair. So we talk about where we want to influence this at. We don't want to cause bleeding again. We really don't want to cause full-blown acute inflammation. What we want to do is kind of go into that subacute inflammatory situation so that we really create an effect on this proliferation and this remodeling phase. We really want to do our work in that area where mitosis is going to occur. And we're going to talk about making sure those inflammatory mediators are released so that we can make this work. The other thing that we talk about with radial pressure wave is we got to talk about pain reduction. It always amazes me. I put this on a patient, I treat the patient with this. Somewhere about halfway through the treatment, the patient looks at me and they say, "Oh, I don't feel it much anymore. You can turn it up." Don't do that, okay? Because again, if we keep turning it up so that they continue to feel it, you know, somewhere on a pain scale of 5 or 6, then we're going to overtreat the area. We're going to create the side effects that we don't want, okay? The other thing that amazes me is as soon as I get done treating, the patient stands up, walks around, looks, whatever, and says, "Wow, this is the best it's felt in a while." Again, that's kind of there. The unique thing, and Dr. Approved will spend more time on this, is that when we talk about pain, you know, we're talking about using this in a chronic situation. We're also looking at now using this in acute situations. There are lots of people that are doing that by using it acutely and even subacutely. You know, I think specifically, really talk about baseball pitchers right after they pitch. You know, maybe the next day is when we would use this device to kind of control the inflammatory process. But what if we used it pre-event to control some pain and do some things simply by not using as much energy and creating the problem? What if we lessen the energy even more? And then guess what? Now we're actually treating in a prophylactic way with this device. Again, the chemical effects, we've talked about all of those. Yes, the one there that we haven't spent much time on is Osteoneogenesis, or Osteogenesis, I'm sorry. When we start looking at osteogenesis, we have to start talking about bone and the way it heals. Lots of good stuff there Dr. Prue will talk about. So just to sum it all up, we're talking about tissue matrix disruption. We're talking about apoptosis and getting tissue to be reabsorbed. We're not really breaking anything down. And by increasing the circulation, by increasing the chemical mediators, guess what? We can now create some resolution and get things really going. Just a couple of studies there. Most everything was done early on with plantar fasciitis, with foot issues, those kind of things. Notice in this one, they used a local anesthesia. Now we've lowered, you know, the power's less so we can treat other things. So most things you'll see are dealing with heel pain and that kind of research. But what we're actually seeing now is that the research, there's so many other syndromes and instances that are being treated with this device right now. So at this point, Dr. Prue, I'm going to turn it over to you.
Thank you, sir. Let's see. So while I'm in this view, you can hear me, Rick, okay?
You're very good. Right on.
So this is the device. As Rick said, it's a physical agent. In this particular unit is pneumatic, so it uses air pressure to generate the necessary energy through a long tube to an applicator, right? And then so inside this applicator, there's a tube and there's a projectile. The projectile moves very rapidly, slams up against this transmitter piece. And inside, we've got various components to it. You can see some O-rings, and there are some differences in the shapes and sizes. Here's another one. Right, so we've got convex and concave. So we're going to use these to actually influence the concentration of energy and the depth of penetration, made up of some different materials and sizes. I'll talk more about that in a moment. So that projectile slams up against, you know, the inside of this guy here, and it creates a very, very small amplitude of motion on this applicator. I'm going to turn it on. Move this closer to me. It generates a lot of power, a lot of force with a very, very short amplitude. And that's why it creates an acoustic wave pattern, sort of unlike, you know, a massage device, right? So they work with very, very large amplitudes, right? So even though you can hear that, it sounds like a lot of energy per unit, you know, it's very, very small in comparison. Has its own place, but it doesn't give us a depth of penetration, not acoustic. And as Dr. Proctor said, that's why we use an ultrasound gel. So we transmit that energy, which is at that moment in time acoustic as it's leaving the tip, and then it hits the tissue. And then quickly through mechanotransduction, we get a very rapid introduction of energy into the tissue. And again, depending on your parameter settings, we can reach 1,000 times more energy than what we see with therapeutic ultrasound, which is why we can't accomplish this with therapeutic ultrasound. I'll show more in a second, but Very, very simple. So we've really only got 4 things to take into consideration, well, maybe 5. So on parameter settings, we have the adjustment of bar or intensity, and then we have the frequency, and then we have the number of impulses and what application tip. So we'll look at that in a moment here. And then, you know, where the boo-boo is as Rick says in the South, I think you called it an ouchie. And we have owies and, you know, whatever else it is you want to call it. But so let's go ahead and pull up my screen here. All right, so you should be able to see that. So I kind of just went over this. All right, so this is just a, you know, sort of a blow up, and it's using compressed air. There are other devices for radial pressure wave. And again, electromagnetics in radio pressure wave versus focus shock wave are still 2 different output components. So the electromagnetics that we use in radio pressure wave devices is similar to, you know, using a motion or a braking system that we see in other types of mechanical devices versus an electromagnetic coil that's generating it in the focus shock wave. But that's a discussion for another day. So the parameters that we do have available to us, we have a frequency setting. So that's a number of impulses per second. It's measured in hertz up to 21. So remember that that's 21 impulses per second, which is a lot of impulses per second. Now, there's somewhat of an inverse relationship on some devices because 21 hertz with a lot of power is relatively difficult to accomplish, and so there may be some minimal capabilities depending on your device. And then we have pressure, which is in bar. So that's kind of your intensity setting, which in bar is 1 bar equals just shy of 15 psi. So that gives you some sense of how much pressure that we're talking about. So if we're looking at a total of about 75 psi or so, think about, you know, your tire in your automobile fills up to about 35, 37 psi. And then we have the depth of penetration, which partly we control through those other parameters because we use frequency settings and the intensity or the bar setting to create that amount of intense wave and then to propagate that wave, right? As Rick showed that picture with the orange and green, right? And it looked different as you went from A to D on that picture scale. It went deeper and more energy because of wave propagation, right? So as we increase the number of waves behind it, increasing dosage, and certainly is going to be depth of penetration. We control some of that to control our target depth with these applicator pieces, right? So this one is called the R40, not that that matters or makes a difference, but so this is one that I use when I want to create a shallow application procedure, or I'm around bony prominences that are very superficial because it can be kind of uncomfortable in certain areas. And then again, we can also control that with our frequency setting in our bar. So the adapters we'll look at here in a second. So the question, you know, does it have to hurt? We spend time on this because, you know, when we first started with this technology, well, me anyway, about 15 years ago, but it's been around even in the US for about 30 years. It's just, we're late adopters typically because of reimbursement and FDA, and not that they're holding up anything in particular. It just depends on whether or not people want to promote it and put it forth to the FDA and bring it to this country. But very popular in Europe, and it's been around for an extended period of time. And so back in, you know, not even 10 years ago, especially with focus shockwave, we used to use analgesics, which we found actually when you use that has an inverse relationship. And the reason is it allowed us, because the patient couldn't feel it, because that's our big component with regards to how much intensity I'm actually going to be using, and that's going to be based on the patient perception. So, you know, if they can't feel it, we could probably overdo it, which is really what we did, and that's why, you know, we, it used to hurt quite a bit, and why, you know, Rick was talking more about we don't go all the way back to causing an injury. I guess the unique aspect is that even when we did, it was still better than the alternative, which was a stalled healing process to getting us back to where we really want to be. So we know, even if, you know, going back to physiology and drudging up bad memories probably, but, you know, when we look at that injury to the repair process, maintenance, and even, you know, the extension into creating, you know, more greater ultimate tensile strength of tissue, yes, that injury is at the beginning stages, but you know, the restoration and regeneration of material doesn't even start until all of that stuff is gone, right? So tissue proliferation, the fibroblastic stage, needs to occur, you know, in the absence of macrophages, right? So if you go back and look at that cycle, that's how we know we're in that tissue proliferation stage. And so it's confusing because when we look at, you know, the terminology with inflammation, you know, we call them anti and pro-inflammatory mediators, these interleukins, these chemical mediators. And probably, you know, when we get to the pro-inflammatory, a better term would be pro-microcirculation, because a lot of people think of inflammation really as negative edema formation, which during the injury cycle is essentially it's a necessary process, especially if we think about from a wound perspective, but we want to get through that as quickly as possible so we don't generate any secondary injury responses. Because blood is a very deteriorating tissue. It's a connective tissue. It doesn't belong inside of compartments outside of the cardiovascular system. What does belong outside of that system are the nutrients and other cells that we want to create in exchange between the cardiovascular system and the other tissue matrix, right? So exercise, I use the analogy of exercise because exercise is it's a pretty similar concept for a lot of the things that we all do in physical medicine, in creating an establishment of a stimulus, introducing a stimulus to then create a response and thereby get an adaptation, right? So like with exercise, we know that we can underdo it, we can overdo it. So does exercise have to hurt? It doesn't have to hurt. But we know that if you're walking on a treadmill and just lollygagging along, you know, you're probably not getting the same benefit per unit time. If you're going to spend 30 minutes on a treadmill, you know, we want to take advantage of that. We typically use, you know, the target heart rate zone, for example. But think about this in untrained sedentary people, we know that below the target zone, they are actually getting a physiological response and or biomechanical response. So it's the same thing here, that we now know that even at lower energy densities, we do have the capacity to be very positive in that response. Now, and that's probably why we're seeing more with these acute types of injuries and why we're able to apply what otherwise seems like pretty intense, which is historically where it's been, to applying it to acute related injuries, because we now know that we don't have to blast the crap out of everything. And so with that exercise analogy, I think it does a great job at sort of implying that, well, you can overdo it, right? So if we train and overtrain really intensely, especially if we don't allow for recovery, right? Because that's the essence of a good training regimen, is facilitating appropriate recovery, which is actually where the adaptation occurs, right? So we're still trying to work on this overload principle to make sure that we actually do stimulate a process, create an overload, thereby instigating an eventual adaptation. So I always refer to this as, you know, getting to the itch that we can't scratch. Oftentimes I use, you know, the like a shoulder impingement of the bicipital tendon, in that bicipital groove, the intertubercular groove inside of the shoulder complex on the humerus, where, you know, if I really want to get to that area, rotator cuff, labrum, and I wanted to use a manual approach, I mean, I have to go through everything superficial. And, you know, I kind of refer to that as, you know, punishing everyone involved or collateral damage, you know, to get to that level. So first off, it's near impossible to get to that level and have that same effect. And so we now have the ability, you know, without damaging and without being too intrusive to other tissues, to get, like Rick said, between 5 and 6 centimeters deep, which is awesome. I mean, that gives us a lot of things to work with, you know, with a device that otherwise I don't have to work too hard with, because really the machine does that. The other cool thing is the immediate response that we get from that. And when we look at, a lot of the satisfaction that we get from patients, and it's fairly immediate, especially with this guy, because if you remember that picture, the figure that Rick showed in comparison between focused shock wave and radio pressure wave, the greatest amount of energy with the radio pressure wave is actually at the applicator. So it's at the surface, which is why we get a lot of stimulation superficially, which is also why, people adapt to it. And we see a relatively quick reduction in nociception, a reduction in pain, within a few hundred impulses. And we're usually imparting, let's say 1 to 4,000 impulses. So it doesn't take that long to really get that benefit. And oftentimes that's associated with an improvement in performance, which is really, what we're trying to accomplish. So to reiterate, do we have to beat the snot out of the tissue? And the answer is no. I mean, we want to slap it around a little bit. We want to kind of show it who's boss, because that kind of reminds us, and again, to use the shoulder as an analogy for calcific tendinosis, to where, we image, yep, there it is. Well, calcium doesn't belong in that tendon. And we're basically reminding the body that that's a foreign matter, in that area. But to be able to accomplish that, this is really the best opportunity using mechanical energy, because like Rick said, it stimulates resorption, it stimulates apoptosis, which is really where this tends to shine over, a lot of other devices, in addition to some of the other things that he talked about. Get a lot of questions on, is it FDA approved? I won't say that doesn't matter, but because as clinicians, we're allowed to perform off-label application. But if we are looking at, this litigation type society that we live in, certainly having devices that are FDA approved, or at least FDA registered, kind of helps support, some of the things that we're doing. So it is FDA approved in temporary increase in microcirculation, muscle pain, and activating connective tissue. So when we think about whatever it is that you're dealing with, that usually falls within line. But like I said, from a standpoint of, what we do, we could provide off-label applications, which actually happens quite a bit. But in any event, devices are what are approved, not application techniques. And a lot of that filters into what manufacturers can actually talk about when they're trying to sell something, versus how clinicians can communicate back and forth, and certainly how we deal with it from a clinical application standpoint. So to look at the side effects, and again, and we're broken records here because we're reiterating the fact that, we don't do what we did 10 years ago, because we do not have to get all the way back to beating the snot out of the tissue and causing an inflammatory response, because inflammation in and of itself, remember, instigates a process of some bad stuff, right? And I use the example as hemophiliacs being one, in that, when blood enters a compartment, especially in an area it doesn't belong. Think about the knee joint, for an example, any synovial joint for that matter. Blood never belongs in there. So it wouldn't make sense that you needed to go back and instigate that inflammatory response back that far. Blood cells break down, red blood cells break down, hemosiderin deposits into the synovium, and it destroys it. And it does the same thing to muscle tissue, connective tissue. So we don't need to go back that far. We know that for a fact. And so we don't have to bring it to a point where we're re-injuring the patient, because again, it's about the recovery and some of the biological processes that occur, with this Graston and other ISTIM approaches. Those biological processes don't even take place for, several days following that treatment. So we need to make sure that we facilitate recovery, because we can overdo it. It's a stress-strain relationship to the tissue, and resulting in that inflammatory process can be negative. Indications, anything opathy, anything osis is where this is really shined. And to me, that's still the biggest benefit right now, especially with radio pressure wave and some of the other things that we have available to us. Although, we've been working on this too. There's some really unique things, like Rick said, from a subacute prophylactic approach in what we can accomplish, and I'll talk about that again in a moment. But really, discussing where this really shines is in those more recalcitrant types of conditions, like I said, the opathies and the OCs in, a lot of the connective tissue and myofascial conditions. So when you look at the summary of the literature, that's kind of where a lot of the focus is. But, more recently, we're seeing some of these changes because of the research and the literature, and frankly, because of off-label application. So non-union fractures is one of them. Yeah, we do have some other approaches that we can take, but again, if I have something at my disposal that's very easy, low technology, low usage, again, we'll talk about the application here in a second, and that's to me another place where it really shines. It provides some increased opportunity for us. And then, like I said, so the prevention or the prophylactic piece. This is actually the picture of this slide is showing muscle tissue and recovering following an intense bout of training and being treated with it wasn't, I believe it was not even on following and training, just normal muscle tissue and increasing satellite cell production, which is again, pretty cool. We're on the verge of basically saying we can accelerate something beyond the normal capacity, which in our physical medicine world, from a conservative approach, non-surgical, non-pharmacological, that's pretty amazing. That's pretty stout. So we're not sure of everything, but at least right now we know that from that chronic perspective, we have some really, really unique opportunities because of its depth of penetration and its ease of application. So when we do apply this, in general, overall, there's about, I'd say on average, about 10 minutes of dedicated time. And that includes, doing your myofascial work too. And what I mean by that is, like we said, you find the ouchie, the owie, the boo-boo, and you're on the boo-boo, right? You may move it around a little bit in kind of a circular fashion, but typically no bigger than like a quarter, a half dollar, because you want the dosage, the energy to get there. Remember, it's wave propagation, so the frequency that it comes out is very different than ultrasound. So we want to make sure that we give the appropriate dosage, but that's what's easy. Anyone can do that, which is also nice because it doesn't take a lot of advanced training. You got to know your anatomy, which, well, in most cases, it's on the boo-boo. So that stationary technique we impart typically between 1,000 and 4,000 impulses. So let me do something right here on. I have this set at 12 hertz, so I'm going to put this on and let's see how long it takes for 100 impulses. Right? That's 102 right there. Multiply that time frame times 10. I didn't keep track, but I know it wasn't that long. And there's your 1,000 impulses. So if you're only doing 1,000, that tells you right there how long that's going to take. So not a lot of time. And then, like I said, there's a dynamic technique. I can then use this like I do with my ISTIM tools to where I can do my myofascial release, but the best part is I get a greater depth of penetration. It's not as great as when you're doing your stationary technique. So you are going to move it slower, but I can do my ISTIM work with this device as well in a relatively short period of time with a greater depth of penetration and the weight of the device. Because remember that you're not compressing the tissue, and in fact, if you do, you're increasing the density, and that kind of changes the dosage. So at least right now, you can do it. It's not a technique though, and that's not the way that the dosage is actually regulated. So typically, if it's a small area, so think about this similar, if you're using laser and like a single diode laser has, an influence of about a radius of 1 centimeter spherically. And this is a very similar approach that, you don't hit every single tissue, although this has a much greater influence than, a single diode in terms of volumetric influence to the tissue. But as far as application goes, that, in small areas, I'm really just going to be applying it one time. There may be 2 spots if I'm, treating a larger arm, for example, but the application numbers are relatively short. And then again, I'm doing my mobility technique. I'll show you here in a second. If you decide to do that, that's secondary. I mean, that's not necessarily part of where the literature is, but it's something that most of us subscribe to, because if you've got lateral epicondylitis, you probably have some referred pain, probably have some dysfunction in some of the musculature and some of the other areas, which is why we tend to address that. We let our patients know, just like any other approach, treatment, or physical agent, what's going to be happening, what the expectations are. Some of these things are loud. So read your user manual. Either you and or the patient might be wearing some ear protection, especially if I am close to the auditory input area. So, do that kind of stuff. But other than that, I mean, the side effects are extremely minimal. And because it's the energy that's coming from the tip, like I said, we're not grinding down or pushing down. You just get to hold it really, really lightly. So there's nothing fancy about the way that it works, which is a nice thing. So what do we got to do? So the parameters, we have pressure, like I said, measured in bar. We have the number of impulses. I put 500 in there because of me. I've just found that, especially the first time I treat a patient, so I can check response, 500 impulses we know still has a therapeutic value to it. It minimizes the chances of over-treating patients, especially if they're more on the acute side of things, than decreasing that overall volume of dosage may be to your benefit. The frequency settings, typically lower to higher, 4 to 18 on the average, about 10 to 14 hertz, especially if you're looking for depth of penetration and you're treating soft tissue versus bone. And so there are some general guidelines out there, but what you'll find is it's not rocket science, and really most of the protocols are pretty much in line, and mostly we're dealing with what's the patient perception. So we're always asking the patient, let me know when you feel a level of discomfort, don't say pain, feel a level of discomfort somewhere between 5 and 7. And the reason for that is that gives us some sense as to the amount of energy that we're putting in and the potential for tissue matrix disruption. That's where your clinical prowess comes in. I mean, we've all worked with athletes that have a very high threshold of pain. We've all worked with athletes that have a very low threshold of pain. So you need to kind of gauge it. And that's why, again, especially when people are learning, I teach them to work on the side, err on the side of caution, using lower energy dosages and total impulses, so they can kind of monitor that and they get a better sense of how the athlete's going to respond and just overall. As I said earlier, to me, one of the other cool things, in my opinion, is the frequency of treatments and the total treatments. So frequency of treatments, if I'm doing that 1 to 2 times a week, on the more aggressive side, it's 1 time a week. Why? Because we are creating tissue matrix disruption. And if you don't allow some level of recovery in the biological and biochemical stimulators to make their way into the area, like I said, it could be a 3 to 5 day delay between when I do this and when we start to see some of those things like vascular endothelial growth factor. Big word for a Friday, term for a Friday, but and I wouldn't want to inhibit that, if that's our actual goal. So, the literature is mostly 1 to 2 times a week. 2 times a week if you're a little bit more on the conservative side, or depending on how you're dosing. What I like about the 1 time a week is, even if I've got a patient coming in 3 times a week, great. That direct contact time, the one-on-one time, is still 1 time a week. So the total amount of time that I spend on them. So again, some of us, break down the schedules, and we've got, for rehab, people coming in from 10 to 12. And then, we've got, game prep or practice prep from 12 to 2, whatever the case may be. It gives us a little bit better opportunity to manage that, because it's not something that needs to be done every single time someone comes in. And then the total amount of treatments. That's another good thing, is typically the range is between 3 and 8, probably 80%. A lot of the protocols are showing, most people respond between 4 and 6, like greater than 80%. So 1 time a week for 4 weeks, that's pretty awesome. So it doesn't take a lot of time per treatment, and it doesn't take a lot of treatments, which is fantastic. So like I said, the lower energy densities you might be doing a little bit more often, so really the acute, the subacute versus the chronic, because you're using a lower energy density. So this is just a picture looking at these different applicator pieces, right? So they easily screw off, and we put the other one, excuse me, we put the other one on. So some of these are made with different materials. These are both stainless steel. There's titanium, there's ceramic, there's Teflon. So they're designed to have different purposes to them, such as, minimizing the output energy and maximizing the depth of penetration, or maximizing the depth of penetration, minimizing the output energy, right? So I probably do 80 to 90% of protocols between these two guys right here. So this one, because of its shape, it lends itself really well for more superficial treatments, and especially if I'm going to be around a bony area, because let me tell you something, when you hit bone, it's its own ouchie, right? So again, it does create some level of discomfort. And like Rick had said, because we're going to be using ultrasound gel, and if it was really sensitive, so, I've treated some really acute people that even, the lowest setting, it was challenging, to treat those people, especially with superficial bony prominences in the area of the pathology. So not using gel also allows us to dissipate that a little bit. So that's the reason for the different applicators. So let me switch screen views here. All right, hopefully I did this right. So it should be a bigger blow up. That look right, Rick?
Looks good.
All right, just a thought. So, like I said, there's a compressor in the back. I don't know if you can hear that. Right. So you can hear, the compressor kicking in as I increase the pressure setting. So that's generating the air that's going to make its way through this tube. Okay. So that we don't have to worry about that. So we're going to take into consideration our application. So most of the time, we start off relatively low. If the patient has a history, I've already treated them, I may be in the area and get minus 25% off, so I can start off not from 0, but a little bit higher. But I usually always start off at around 4 hertz as minimal, and then I always start off at 1 bar. Like I said, unless they've been treated before, I can always turn it up. But once you hurt someone or make them uncomfortable, it can be a little bit of a challenge to get them back. So let's say I am treating a lateral epicondylitis. So I take my gel here, and again, typically it's a stationary technique. So kind of like if you're using a class 3 laser, okay? So it's more, I've got more than enough gel on there, and I put a little bit more on there for a reason you'll see in a minute. And then I use topical agents, some better than others. This one has a good viscosity to it, so it doesn't gunk stuff up. But even though it's an analgesic, and we said earlier a couple times, that we don't use analgesics anymore because if the patient couldn't feel it, we turned it up too high, right? I still use some because by the time I put my parameters in, we're already going before the analgesic actually kicks in. So we find the boo-boo. So you can hold it like a pencil. You can hold on to the top. So right now I'm at 4 hertz at 1 bar. So I know that, you know, if the protocol is going to be at 12 hertz, I'm going to increase the frequency first. I only got one hand at the moment, so I'm going to go ahead and do that. So I'm up to 12, and now I'm going to increase the pressure setting. And I say to the patient, let me know when this feels uncomfortable at about a 5 out of 10. And of course, you established that before you started. And we'll say right about there. And you try to do that within about 150 to 200 impulses. Okay. You may move it around a little bit the size of a quarter, but you see that I'm not translating all up and down the arm here. It's right there. You can see the dot where I am. You can pick it up. You can move your gel back into it if it starts to move around, because it does on some of these tips. But you want to get the dosage in that area. So at 12 hertz, I don't know, maybe it's Friday. I'm going through the whole thing. 3, 2, 1.
Lasts longer.
Right? So that was 1,000 impulses. That's how long it took. So that wasn't a great deal of time, right? So I always do the point stuff first, and then you consider your pathology. And again, we could be having some issues with referral pain patterns, trigger points in the extensor group. And so then I will go ahead and do my myofascial release technique. All right. It's not hard. Basically, it's slow. You are following the anatomy. So that does make a bit of a difference. The other thing I like about using a topical and analgesic is, one, if you're using one that enhances, you know, tissue recovery, that's a wonderful thing. But from the patient experience and the benefit that we get, it's fantastic. So really simple, really easy. And let me go back to my picture here, my slides, because we need to finish up. There we go. All right, that was the last slide. So thank you for your time. I hope this was informational. Like I said, we've got the next series coming up is going to be on laser. And so we'll talk about low power laser and high powered laser. Look for that in September. Our email address is rick.proctor@djoglobal.com and chris.prue, spelled P-R-O-U-L-X, so not like it sounds, @djoglobal.com. Feel free to ask us any questions. I mean, we can't sell you anything, but we certainly can, you know, answer clinical questions. And if that works out, feel free. So enjoy your Friday. I hope everyone's staying safe, and hopefully we're getting back out there and getting a little busier than we were before. I know it's a little different depending on your area that you are. All right. I think that
doesn't look like we have any questions.
Well, I went over. You know, I was so good the rest of the week. So everyone's probably got to go and eat lunch or do all that kind of stuff. So if you have questions, seriously, just send us an email or you know, through the registration website, and we'll send it off.
Sounds great. Thank you.
That camera. I got this camera going, and we'll send it off. All right, folks, have a great day.
See ya.